Have you ever been in therapy trying your absolute best to explain what it's like to live with a dissociative disorder, and you just get this feeling that you're not being heard, like you and your therapist are speaking two completely different languages? Well, today we are going to get into exactly why that happens. It is not your fault, and it all comes down to a really deep fundamental misunderstanding. This quote, let's just hits it right on the head, doesn't it? It's that absolutely maddening feeling of frantically pointing to a real, live, burning fire, and the person who's supposed to help you just keeps telling you to take deep breaths. They're focused on your reaction instead of the very real danger that's causing it. So, this brings us right to the heart of the problem. It all kicks off with one single, really powerful, and honestly, often misused concept: emotional dysregulation. We're calling this whole mess the dysregulation trap. This is such a classic example, right? A therapist sees switching, which is a core neurological feature of DID, and their brain immediately files it under emotional outburst. And what's the solution they offer? Use some skills to get more control, as if the very structure of your brain, the existence of alters, is just a bad habit you need to breathe your way out of. Okay, so this slide just lays it all out. On one side, you've got the actual neurological reality. Your brain's hardware is literally partitioned. That's what structural dissociation is. But on the other side, you have this behavioral label that gets slapped on top. It treats switching like it's a choice or a failure to cope. They are trying to fix a hardware problem with a software patch, and it just doesn't work. So you have to be wondering why. Why do so many well-meaning, educated professionals fall right into this trap? Well, the reasons are often way more about the system they work in than they are about you. The honest truth is, for a lot of clinicians, diagnosing and treating DID feels incredibly risky. They're scared of looking foolish to their colleagues, they're worried about professional backlash, and they are definitely worried about the liability that comes with acknowledging severe, complex trauma. So what do? They fall back on what's safer for them administratively, diagnoses like borderline personality disorder. It's a practice called defensive charting, and it's designed to protect the provider, not the patient. And this is the devastating result. When a therapist picks a safer diagnosis to cover their own liability, the message they're sending you, whether they mean to or not, is that your reality, your entire existence as a system, is not allowed. It's denied. Now, to really understand why standard therapy so often just completely fails, we need to talk about a really powerful analogy: the mismatched operating system. So first, let's be super clear on this. Structural dissociation is not a disorder of emotion. It's a disorder of structure. The brain's actual hardware was partitioned as a way to survive something unthinkable. We're talking about how your consciousness and memory are physically stored and organized. And this right here illustrates the problem perfectly. Most therapy is like software that's designed to run on a single mind operating system. It just assumes there's one continuous consciousness driving everything. But a person with DID, you're running a multi-mind operating system. And what happens when you try to run single-mind software on a multi-mind machine? It doesn't just work poorly, it crashes the whole system. Let's build on that with another little story. Think of a restaurant, but it has no manager to coordinate things. So the employee at the front, that's the fronting alter, takes a customer's order. But there's this big amnesia wall, so they can't get the order ticket back to the kitchen. The kitchen staff, the other alters, they never even get the order. The result? Total chaos, right? This isn't about someone not trying hard enough. It's a complete breakdown in the system's internal communication. And this leads us right into the DBT trap. Therapies like dialectical behavior therapy, DBT, they often rely on things like diary cards, where you have to track things continuously. But for a system that has amnesic barriers, that is functionally impossible. The alter who's fronting on Tuesday might have no idea that the alter from Monday even started a diary card. And then this neurological barrier gets misinterpreted as you being willful or non-compliant. It creates this impossible catch-22, where your therapy gets held hostage until you can do something your disorder literally prevents you from doing. So, and this is so important, this whole misunderstanding isn't just ineffective, it's not just a waste of time, it is actively harmful. It creates a cycle of betrayal and re-traumatization. Look at this slide. It shows the devastating translation that happens in clinical notes. You come in with a legitimate medical crisis, a broken toe, you haven't slept in 3 days, and it gets documented as you being dramatic or seeking attention. You try to talk about your identity as a system and it gets labeled delusional.
A real trauma trigger gets reframed as you having a behavioral problem with your therapist. Your reality is systematically rewritten as a character flaw.
And that's the feeling it leaves you with, isn't it? That profound, deep isolation of trying to communicate a real crisis and just being told over and over that what you're experiencing isn't real. It's like you're just screaming into a void.
And the consequences of this are so severe and they are so real. We're talking about everything from medical neglect of actual physical emergencies to the deep, deep psychological wound of institutional betrayal, where the very system that's supposed to help you ends up mirroring the dynamics of your original abuse.
You know, one of the most painful examples of this is a technique called gray rocking. This is when a clinician decides that your distress is a behavior that they shouldn't reinforce. So what do? They intentionally withhold all empathy. They become a blank wall. In their mind, they're being clinical. But what they're actually doing is flawlessly replicating the cold, punishing, emotional abandonment of an abuser. Okay, so knowing all of this, what can you do? How do you even start to advocate for the kind of care that you actually need? How do you begin to fight back against this narrative?
Well, the goal isn't really to fight, it's to educate. The whole point of this last section is to give you some clear, clinical language that can help you bridge that enormous gap in understanding.
This is such a powerful phrase. Using it can shift the entire conversation. You are basically saying, stop focusing on my feelings or my behavior. This is about how my brain is wired. You're moving the discussion from the realm of psychology into neurology. And here's another key phrase, using that operating system analogy we talked about. This makes it clear that this isn't about you failing therapy. It's about the therapy failing your system. It explains the core problem without placing blame, and it forces them to actually confront the limits of their own tools. And finally, it's about reclaiming your accommodations. That need you might have to write everything down in detail. That's not you being obsessive. It's a necessary prosthetic for your memory. Needing to record sessions isn't about a lack of trust. It's a completely logical tool to deal with amnesia. These are not character flaws that need to be fixed. They are intelligent, functional adaptations for a fragmented brain, and they need to be supported. So we're just going to leave you with this question. Because when a therapeutic model misunderstands you this profoundly, it stops being a tool for healing. It becomes a system of control, one that demands you pretend to be normal as a ticket to get help for your trauma. And that is a cycle that absolutely has to be broken.